historically, so maybe a decade ago, we really only had a few structural alterations that we considered high risk, and we would take anybody to transplant that had a matched sibling donor, or maybe patients that had a poor response to initial chemotherapy. But ultimately, probably what that meant was we were taking some patients to transplant that didn't need to go to transplant, and probably missing a lot of patients that needed to go to transplant that weren't going to transplant, and then ultimately would relapse, and we would try to salvage them. So in the ongoing phase 3 trial through the Children's Oncology group, we've updated that risk stratification. So now we have a lot more high-risk alterations that have been found through next-generation sequencing, and looking at independent publications from other large collaborative groups. And ultimately, the amount of patients that are considered high risk based off of their cytomolecular alterations has increased from about 13% in those historic trials to 32%. But as we kind of continue to refine these definitions and generate larger sample size, we're starting to identify more alterations similar to the TP53 that I was just talking about that probably deserve to be considered high risk. And so, again, working with the Masinchi lab at the Fred Hutch Cancer Center, and then collaborating with the Myeloid Disease Committee through the Children's Oncology Group, we looked back at the two most recent trials through the Children's Oncology Group for de novo AML. So the names of these trials are AAML0531 and AAML1031. And what we did was we looked at a lot of different rare alterations, and if those alterations had poor event-free survival on successive clinical trials, so on both of those clinical trials, we thought that they potentially warrant readjusting their risk allocation. And so similar to TP53, we actually identified 5 other alterations that we would consider for a risk adjustment. And these are CEBP alpha with a CSF3R mutation, CREB-BP mutations, partial tandem duplications in KMT2A, IDH mutations that don't have a co-occurring NPM1 mutation, and then a group of mutations in the ETS transcription factor family. And so if you add up all 6 of those lesions, they're all very similar to the TP53, where they're actually very rare. But when you add them up as a group, it makes a non-insignificant group of patients. And so specifically, I had mentioned that currently on the ongoing clinical trial, we think about 32% of patients are going to be ultimately considered high risk and taken to transplant just based off of their cytomolecular alterations. Well, if we incorporate all 6 of these new alterations in, that would increase the distribution to 37% of patients being considered high risk just based off of their cytomolecular alteration. And again, that's not a huge number to move the needle significantly, but for those 5% of patients that have these mutations that maybe wouldn't otherwise be getting a transplant in first remission, I mean, it does make a really big difference. And so we looked at this group as a whole, and we just compared what does their event-free survival look like compared to contemporarily defined high-risk patients. And as we anticipated, they had an analogous event-free survival to those contemporarily defined high-risk patients. Now, interestingly, there are a handful of these patients that do have co-occurring low-risk alterations. So I had mentioned that CEBP alpha with CSF3R. Well, those patients, they have a high risk of relapse, but they also have a relatively good overall survival, suggesting that they can be salvaged with a stem cell transplant. And so I think that not all of the patients in this group of alterations are created equal, with some patients having a relatively dismal overall survival, like those TP53 mutations, but then some patients that can be salvaged with stem cell transplant, like the CEBP alpha CSF3R.